Greetings, everyone. I'm Dr. Wu Pang Hong from Singapore. Hi, everyone over there in Mumbai, India. It's sad for me that I cannot attend this year's endoscopic spine foundation India meeting because of my national service where I'm on standby. Today, my topic is on cervical endoscopic surgery for cervical myelopathy. This is my conflict of interest. Some of them are relevant for this topic. I think true spinal endoscopic benefit is in complicated cases, and certainly cervical myelopathy is one of the complicated cases in spinal surgery. We analyze critically, and often in cervical myelopathy that presents with a significant drop in MJOA, they will be in a grade 3, a grade 3 area where there's signal intensity over the spinal cord on T2. And we also analyze critically whether left or right side there's any radicular symptoms. Why do we do endoscopic surgery? There are common known risks in anterior cervical spinal surgery, such as dysphagia, dysphonia, and hematomas leading to airway compromise. Implant-related complications, and one of them being not really labeled as complication is that of adjacent segment degeneration on top of screw loosening plate and cage related problem, as well as for disc replacement, the unknown period when the disc replacement may wear out and eventually need to be replaced. For open posterior cervical surgery, there are known common risks of chronic and persistent neck pain, wound issues, cause of implant-related issues. And why not do tubular cervical surgery? I think for foraminotomy, tubular surgery and endoscopy can be applied to the patient, but for myelopathy and over-the-top decompression with ULBD, doing tubular surgery where you need to wind the tube in open cervical spine is really risky, stressful for the surgeon and probably stressful for the patient. And what if there is bleeding? Can't really see very well in tubular surgery. For the endoscopy that can be applied for myelopathy, you can do ACDF and through the biportal assisted manner. But for today's purposes, we'll be discussing really uniportal or biportal method. And in today, due to limited time, we're talking about biportal, mainly on that of the either ULBD, unilateral laminotomy with bilateral decompression, or really the more commonly practiced laminectomy. And for foraminotomy, we focus on this as to the lateral to the cord. But for myelopathy, we'll be looking at whether cervical stenosis is out of, in my practice, less than 3 levels and with no significant kyphosis. Majority of the compression come from posterior. And in some cases of anterior, where corpectomy or anterior surgery will be challenging or contraindicated. How to decide whether to do UBE by ULBD or laminectomy? For this, I thank my fellow Rohit who spent precious time with me in Singapore. We published a paper on this, published in NASH journal, when we discuss what are the strategies and management of spinal cord compression. And as you can see from this diagram, that we can do either a laminotomy, bilateral decompression, or laminectomy, where it's like the figure E, where we make two trough and remove the lamina, sparing the spinous process. And I also thank my mentor who has taught me the uniportal techniques, but for today's time, we do not have time to discuss too much on uniportal. Needless to say, both uniportal and biportal have very good results. For this case example, I would like to thank my current fellow. He's also called Dr. Wu Chunsui from China. He's a deputy chief in Nantong Orthopedic near Shanghai. This patient is a 64-year-old. He has instability, walking on the phone for 1 year, was in the past 3 months. His Hoffman's positive, unsteady gait, power 5. However, in all four limbs, a taxi driver. He requires neck movement in driving taxi, and he insists that he will continue driving. And as you can see, that this patient have very severe spinal stenosis due to OPLL, as well as that of a thickened ligament at the back, leading to a severe spinal stenosis with myelomalacia. And you can see from the diagram here, there's a thick OPLL from the back of C3. As you can see, in this type of more serious cases, we tend to use Mayfield clamp rather than horseshoe. Of course, controversial of which one is better. By standard, Mayfield clamp is quite easy to apply, and the patient has not much problem with the pins. So I use Mayfield clamp. This is the marking of the spine. We have the viewing port at C2 and the working port at C4. So through two port, we can do a C2 to 4, actually on top of 5 decompression. This is a video showing the water that we use. You can see that use very little flow. And you can see the bag is actually at the level of the cervical spine. And that's sufficient for the water in decompression. So first, we create a working space. We use radio frequency, and then subsequently check the location. And then we find the V points by doing radio frequency and some drilling. Subsequently, we do the ipsilateral laminotomy. After we do sufficient ipsilateral laminotomy, there will be bleeding points, and using a small tip radio frequency will be really helpful. Be very cautious in the laminotomy. Although we do the ipsilateral laminotomy, do not breach the flavum, nor do you drill till we actually see the spinal cord at this point of time. Just make it thin, create working space. The working space actually involves the ipsilateral side and the contralateral side. Along the way, you will have threaded tissue on your drill, and you can ask your assistant or your nurse to clean it up. Now, after drilling, there will be sufficient space in the ipsilateral side. And then we work on the contralateral, on the caudal laminotomy, again creating space. For this particular case, we do all the way to end of the C4. So this is the entire C3 and C4 laminectomy. After that, we check the location, whether we are at the midline. Of course, you also can see the midline cleft. Then we proceed on to the contralateral side, keeping the ipsilateral side lamina still very much intact, just drilling it in. To spend a lot of effort and time to carefully drill for the lamina to be lateral enough. Keep the flavum intact, drill the lamina thin. If it's a ossified yellow ligament, you drill the yellow ligament as well. Once that is thin on both sides, actually, we will remove the flavum ipsilaterally and then contralaterally without in an atraumatic fashion. To open up the lamina, you can use a nerve hook or that sort of gentle kerosene. I tend to use a nerve hook first, create some space, let the saline enters gently to the cord. Be very much lateral to the cord before you actually put in your kerosene. Don't be putting your kerosene right in the middle of the cord. And then you can gradually, using this towel hook, to remove flavum as well as that of the of the bone, if there's any residual ones. There's bound to be some bleeding. Be patient. Bear in mind, my saline flow is really low. The bag is at the level of the bed. So if that bleeding happens and it's copious, can stop and use a flow seal or any hemostatic agent of your choice. But keep the scope in so that you will be oriented always. And then we mark the top and the bottom level of the decompression, confirm the levels. And this is the results of the patient. So it comes laterally, but you can see that the wounds are, well, the wounds are very pretty clean. And the next day, the patient is able to ambulate independently. So it comes out laterally. So the drain, you can see, is very minimal. It's just about 50 mils. Overall, we can do decompression for short OPLL, OYL. Um, and we keep the water pressure low through the laminar tubing to remove the lamina, and then last to remove the phlegm to decrease bleeding. Finally, we like to emphasize that there's a steep learning curve in endoscopic spine surgery. We need to be familiar with handling of endoscopic drill, especially in doing cervical cases, as we need to drill the bone very thin. Fluid pressure really maintain low as possible. Just be visualizing well. Try to do most of the cervical surgery in less than 1 hour because prolonged water pressure on cord is not a good thing. Of course, if you were to do multiple levels, then remove the ligamentum flavum last so that you will expose the cord to water of the normal saline to a limited period of time. Try to have no contact with spinal cord. Use small equipment like horizon 1 or forceps. And we have proper hemostasis and be clear of what you see all the time. With that and careful choice of patient, you will get good results. If possible, we would seek collaboration with our partners. Most of you and all of you are endoscopic experts. Please submit your paper to consider to submit a paper to Medicinal Journal where Professor Hyosung Kim and myself is the guest editor. The deadline is August this year. Thank you very much.